Hi, Mike Gibson, Bobby A, talking about the Agent IDE trial, comparing a new drug-coated balloon versus traditional POBA in the treatment of in-stent restenosis. Bobby, talk to us a little about the mechanism here. It's fascinating, and then what you found.
Yeah, this is a the agent balloon is a drug-coated balloon. It's coated with paclitaxel in a low dose formulation. The paclitaxel itself is sort of developed in a way that takes on a crystalline form that is, lipophilic. It embeds itself in tissue. It stays there. It has interesting properties that make it highly transferable just with the inflation of a balloon. So we were excited to evaluate this balloon compared to conventional balloon angioplasty or POBA in patients with coronary ISR for this part as part of this trial.
These crystals are getting into the wall of the vessel. They're not being washed away. I mean, they're getting into the wall.
That's right. They're getting into the wall, and the nature of paclitaxel itself, it's sort of different than the properties that you need for a drug for a stent, for example. The properties required for the you don't want it to sort of come off as you go through the bloodstream or fall off as you sort of slide down the vessel. Then in a short inflation period, you want it to be highly transferable and then stay around in tissue. And it just turns out that the properties of paclitaxel are such that it's very effective in this setting. And here, where paclitaxel is, cytotoxic, it's strongly inhibitive of neointimal proliferation in these small dose formulations. It becomes effective in this sort of device.
Yeah, of
At least that was the hypothesis.
course. And so talk to us about the design of the study, Bobby.
Yeah, this is a randomized controlled trial. It's a 2-to-1 randomization where for 2 patients who received the agent IDE, one patient would undergo conventional angioplasty. For coronary ISR, lesions between 2 and 4 millimeters, less than 26 millimeters in length. For native coronary artery in-stent restenosis cases, it could be drug-eluting stent or bare metal stent restenosis. You could have had one layer of stent. You could have had multiple layers of stent. Those were all part of the trial.
Bobby, I'm a direct stent kind of guy. Did you pre-dilate before you put this drug-coated balloon in,
Yeah.
or did you go directly with the drug-coated balloon? How
No,
does
you had to demonstrate that you achieved an acceptable angioplasty result before patients were randomized.
okay?
That was because if you didn't want too many people getting bailout stenting post-randomization, for example. So you needed to achieve a decent result with balloon angioplasty, less than 50% residual stenosis. And at that point, you were randomized to an additional inflation with either drug-coated balloon versus another non-drug-coated balloon.
And what did you find?
Well, the primary endpoint was 1-year target lesion failure, which was the composite of ischemia-driven target lesion revascularization, target vessel myocardial infarction, or cardiac death. And at 1 year, the event rate in the POBA arm was 28.7%. In the DCB group, it was 17.9%. That was a 10%, greater than 10% absolute risk reduction, highly significant superiority p-value of 0.0063. If you look
Wow.
at
So,
components,
the way the cost people look at it, if we had Dave Cohen here, he'd be saying, well, you'd only need to treat 9 or 10 people to prevent one TLF, and that's pretty cost effective, right?
yeah, yeah, potentially so, I think. And if you look at the components of that, as you might expect, heavily driven by ischemia-driven target lesion revascularization, where the event rate went from 24% in the POBA arm to 12% in the drug-coated balloon arm. But interestingly, target vessel MI also reduced by 50% in the trial, 12% in the POBA arm, 6% in the DCB arm. So, reduction in not only, significant reductions in not only in TLR, but in target vessel myocardial infarction. Sometimes we think of restenosis as this benign entity that's presenting stably, but in this case, actually a very large fraction of these patients represented with actual myocardial infarction during their recurrent event.
And Bobby, the next questions are: were they STEMIs, non-STEMIs? How big were they? Were these troponin leaks?
Yeah,
Talk to us about the size of these MIs.
yeah. We haven't dived into all of those data just yet. These data are truly hot off the press. We were actually originally thinking about presenting at a later meeting, in fact, and We decided to sort of expedite things because we just got the results recently, but these are all really important questions. Actually, just had a phone call today to discuss the importance of really trying to understand these events that are occurring in follow-up.
And any subgroups that benefited tremendously, small vessels, any of those pop out?
Yeah, I think the most interesting subgroup analysis that we've looked at thus far, and again, these are very preliminary data, and of course, these are highly underpowered, but 40% of the patients in this trial had multi-layer ISR. So they had undergone previous stenting at least two times, sometimes many cases more. So these are lesions that are recurrently failing. And so this is like sort of the highest need group. And we think maybe these are patients who just wouldn't benefit at all, that they're just doomed to have restenosis. And in fact, the effect size here on a relative scale was equivalent. We had dramatic reductions in the primary endpoint, as you were seeing in the main trial, 50%, 50% reductions. But of course, because these patients had a higher risk of events, their absolute reduction was bigger. So they had even more benefit on sort of the absolute sense, the absolute scale for the multi-stent layer. So that really fulfills a pressing need, I think, a clinically urgent need for these patients who you really don't want to put an additional third, even fourth layer of stent for some of these patients.
Any, how about LED location, 2 millimeter vessel size, anything there?
Yeah, we don't have all the results for the different subgroups as of yet. You know, on preliminary view, as you might expect in a 480 patient trial, that there's no obvious signs of there being heterogeneous treatment effects. Now, I will say that we are reporting 480 patients here as the primary endpoint, but the trial ultimately enrolled 600 patients, and we don't have complete data on the 600 as of yet. Those data are to come. And the reason that happened is because 480 patients was the original design of the trial, but there was an interim analysis that would have allowed us to enroll up to 600. At the time that the interim analysis was meant to be performed, the trial enrolled so quickly that we didn't have any follow-up on patients. And so the DSMB said, well, we don't have any information from this interim analysis. Why don't you just go ahead and enroll up to 600? When we did finally have enough patients to have follow-up, when we looked at the power calculations as originally planned, 480 turned out to be adequately powered, and both the DSMB and the FDA requested the 480 analysis, which we're now presenting at TCT.
So I'll never forget when the J&J stent came along, and all we had was the Turco Rubin stent. Someone asked Don Bain, "Where do you now see the GR stent?" And he said, "In the museum, the Smithsonian." Where do you see radiation therapy in the future?
Well, you know, interesting because I think people will have different perspectives on this. As you know, brachytherapy is not widely used across this country. It's limited to a specific number of centers. I think it's difficult to maintain those centers. I suspect that this device will, you know, by and large, be the first or second line treatment for patients with in-stent restenosis if it's approved by the FDA. If they look at these in conjunction with the totality of the evidence for this device, if it gets approved. But I still think that there's going to be a role. You know, we had certainly the event rates were much lower with this device than with POBA, but they were not low. There was a 17% event rate at a year. So there are going to be patients who continue to come back with ISR. I don't think this eliminates ISR, and it's not going to eliminate the need for us to have continually develop, I think, new and innovative ways to deal with the problem.
When will we be able to access this kind of technology in the US? Can you say?
You know, I don't know exactly what the plans are for regulatory submission. I know that, of course, it's, you know, this is a study sponsored by Boston Scientific, and they're, of course, like we are, highly interested in having the device become available. I know that everybody's working furiously to make that happen quickly. My hope is that, you know, I think you and I both see that there's a strong clinical need for a device like this. My hope is that it's done in as expeditious a fashion as possible, and hopefully these data go a long way to supporting that.
Great. Well, Bobby, thank you. Thanks for sharing the results, and thanks to all of you for tuning in.
Thanks, Mike.